All right, well, why don't we go ahead and get started? I want to welcome everyone to the Coordinated Care for Patients with Breast Cancer Brain Metastasis education session. We're excited about this session and are hopeful to touch on many of the nuances of the care of our patients with brain metastasis arising from breast cancer. And I'm thrilled to be joined by this esteemed group of multidisciplinary partners and experts across the spectrum of brain metastasis care. I'll ask each of them to introduce themselves. We'll start with Dr. Wefel.
Yeah, hi, my name is Jeff Wefel. I'm a neuropsychologist at MD Anderson Cancer Center, the chief of neuropsychology jointly appointed in neuro-oncology and radiation oncology.
Hello, everyone. I'm Helen Shih. I'm a radiation oncologist at Massachusetts General Hospital, where I'm the director of the CNS and ocular tumor programs and a medical director for proton program.
Hi, good afternoon. My name is Nelson Moss. I'm a neurosurgeon at Memorial Sloan Kettering, where I co-direct the multidisciplinary brain metastasis program.
I'm Chris Lascola. I'm at Duke University. I'm a member of the Center for Brain and Spine Metastasis and a neuroradiologist.
Hi, I'm Rebecca Dent. I'm a medical oncologist at the National Cancer Center in Singapore, as well as at Duke NUS Singapore. There's a Duke Singapore. I've been there 13 years, but originally from Canada.
Excellent, and I'm Carey Anders. I'm the medical director of the Duke Center for Brain and Spine Metastasis and a breast medical oncologist. All right, well, just briefly our disclosures. All right. So why don't we go ahead and get started? I think everyone in this room is aware of the challenges that we face with breast cancer brain metastasis. This is a devastating, feared, increasingly common consequence of breast cancer, with an incidence as high as 30% amongst our patients with HER2-positive disease and 50% amongst those with triple-negative disease in the advanced setting. You'll see here a figure of the blood-brain barrier. I would argue this is the blood-tumor barrier in the setting of metastasis, which has efflux pumps inherent to the brain endothelium, which effectively limit the exposure of cytotoxics when we're trying to treat brain metastasis with systemic therapies. And historically, clinical trials have been relatively few in the history of breast cancer clinical research, but I think we're really seeing a shift in the tide here, where we're seeing clinical trials not only allowing our patients with brain metastasis, but specifically focused on this patient population. So we elected to make this session case-based. The first case is going to focus on a patient with HER2-positive brain metastasis. She is a 37-year-old female who was originally diagnosed with breast cancer in her late 20s. She had oligometastatic breast cancer to bone. And her diagnostic biopsy was actually of bone. It was estrogen, progesterone receptor positive, and HER2 positive on this bone biopsy. Based on her young age, limited metastatic disease, the decision was made to proceed with curative intent chemotherapy, and she received our standard neoadjuvant TCHP regimen. She underwent a right mastectomy, had postoperative radiation therapy to the chest wall and regional nodes, and then transitioned to standard of care with ovarian suppression, an aromatase inhibitor, trastuzumab, and pertuzumab maintenance therapy. So about 3 years later, she presented to clinic and described some subtle changes in her handwriting and some word-finding difficulty. So based on the fact that she did have a history of high-risk HER2-positive breast cancer, the decision was made to order a brain MRI. And in fact, this did show evidence of CNS metastasis affecting both her left parietal lobe as well as her right cerebellum. So what do we think about in terms of an initial presentation of brain metastasis? Some of the findings can be quite subtle. I would say this patient had sorry, there's a timer on here. Some of them can be quite subtle in terms of word finding challenges and changes in handwriting. Some of the more common symptoms that we see in the clinic include headache, nausea, vomiting, motor weakness, many times one-sided. And unfortunately, in some cases, patients present quite late. We can see seizures as an initial presentation or increased intracranial pressure. This is important to consider in the setting of our patients who are at higher risk for brain metastasis. We've discussed both the advanced triple-negative setting and the HER2-positive setting. And we also do consider the possibility of brain metastasis for our patients who are receiving adjuvant HER2-directed therapy, as was this case. But at present, there are no current guidelines to perform routine surveillance brain MRIs in the absence of symptoms. And in fact, most of the guidelines don't recommend for or against. So you can use your clinical judgment here, and there are prospective studies in this space ongoing. So I'm going to turn over now to Dr. Lascola to tell us a little bit more about the radiographic characteristics of brain metastasis.
All right, I'll try to do this without a pointer, or maybe I'll, okay. Yeah, so most of you, I imagine, have seen brain metastases on MR. That's the gold standard right now, a gadolinium-enhanced exam, which allows gadolinium to extravasate across a disrupted blood-brain barrier where the lesion is and produces high signal on T1-weighted images. Do I just point? Oops. Where's the pointer?
To your left. This green thing.
This thing?
The green, no, this one right there. Oh, the pointer. I think I'm sure it's on that. Like that. Yeah. Try that. I can't see.
I've already screwed this up.
Here, we'll go back. Let's do the red.
There we go. That's not a great pointer, though.
Okay. Okay.
Hit the red button, Chris. Go back.
Okay.
And then you can, if you want to point over to there. Yeah.
Okay.
It's a long way.
Long way over.
All right, so metastases can present as a solitary lesion. They can present as just a few lesions. They can present as innumerable lesions. They can be necrotic. They can be solid. Many times, the clinical symptoms are actually due to the surrounding edema. Edema is not present all the time, though. Occasionally, small lesions, particularly peripherally in the cortex, don't have any edema whatsoever. They can present as hemorrhagic, and that's a term that I think requires a little bit of clarification. Most people use the term hemorrhagic if there's a little bit of small blood products within the lesion, or if there's actually large volume hemorrhage associated with it. So it's a broad term. It probably needs to be clarified. You can also present with dural metastases. These are actually quite rare. They're usually driven by metastatic disease in the calvarium, and then it extends into the dura. But in breast cancer, you can have isolated dural metastases rarely. And then you can also present with diffuse leptomeningeal disease, which we're going to talk about later because there's some nuances to that. But one of the things that I wanted to just point out right now is that I think sometimes there's confusion for grouping dural-based disease as leptomeningeal disease, and in fact, they're two different things, and we're going to talk about that in a little bit. And the other thing I wanted to mention, and this is in the case that's in the middle case in the bottom row, is that even though MRI is great, it's certainly a lot better than CT, which is actually what we used to use 10, 15 years ago all the time, is that it's not perfect. And in some cases, we're no doubt missing a significant amount of disease. And in fact, this was just a case from about a month ago where we suspected that there might be a lesion present in the posterior fossa, but we weren't sure, so we brought the patient back for a delayed scan where we waited about 10 minutes after we gave contrast, and then we also added something to the sequence to improve the contrast to background ratio. And the patient went from maybe having 1 or 2 lesions to about 50. So right now we're working on new techniques to try to make this more standard. I'm sure we're missing a lot of lesions. But that's sort of the gamut of CNS intracranial metastatic disease.
Excellent. So one of the things we've talked a lot about in the literature is the neurocognitive sequela of treatment of brain metastasis and how to avoid that. And we actually wanted to spend some time discussing the neurocognitive challenges of our patients at the diagnosis of brain metastasis. This can be relatively under-recognized. So I want to turn it over to Dr. Wefel to go over not only some of the neurocognitive challenges, but the mechanism of behind what we're seeing.
Yeah, thank you very much. So really this starts probably at the time of diagnosis of cancer. So this simplified curve are going to demonstrate to you some of the threats to brain health and cognition that cancer patients experience even before they develop a brain metastasis. So as you see on the left side of this curve, you have cancer diagnosis and then non-CNS directed therapies, things like our chemotherapies, immunotherapies, hormonal therapies, and maybe radiation therapy, not to the brain. And those are also associated with cognitive impairment. So patients presenting with brain metastasis oftentimes have already had exposure to these treatments and may be presenting with cognitive impairments due to those lingering sequelae of those therapies. Then patients can develop brain metastases and have CNS-directed therapy, and of course those can contribute to cognitive impairment as well. So just keep in mind that there's this spectrum or continuum of survivorship that our patients are experiencing, and that they can develop cognitive problems at multiple points along that continuum. So what are some of the potential mechanisms of this chemobrain phenomena? There have been a number of things that have been identified in the literature. Mitochondrial dysfunction arising out of oxidative stress, neuroinflammation, alterations in hippocampal neurogenesis, alterations in neurotransmitter activities, and a growing story around microglial dysfunction and microglial dysregulation that may be underlying a lot of these processes. And this is a meta-analysis of many of the prospective longitudinal published studies that demonstrates that women with breast cancer who have received chemotherapy demonstrate worse cognitive function across a number of different domains compared to healthy controls, including in areas of learning and memory, executive function, attention and concentration, information processing speed, and expressive language abilities. We also know that there are a number of other endocrine therapies that can also cause cognitive disturbance. It's not all chemotherapy. We know that estrogen receptors are densely located within the temporal lobe and hippocampal circuits. There have been a number of studies that have examined the effects of endocrine therapies on cognition, and in summary, it's been demonstrated that tamoxifen seems to have greater adverse effects than aromatase inhibitors, particularly in the domain of memory function. There's neuroimaging evidence of adverse impacts on brain, in case you don't believe the cognitive test results. There's been evidence of diffuse reductions in gray matter, alterations in white matter integrity, functional hyperactivation as well as functional hypoactivation, and alterations in structural and functional connectome properties. What's shown below here are reduced gray matter network organization in breast cancer patients compared to controls. These patients oftentimes are neurologically complex. They don't simply present with cognitive problems. They tend to have poly symptoms as far as the neurologic symptoms are concerned. The Vienna group looked at their medical records and identified over 1,600 patients with brain mets from non-small cell lung cancer. And what they found were that nearly 3/4 of these individuals were presenting with neurologic symptoms. Maybe that's not surprising given that we have a structural lesion. 60% had focal deficits, 30% had increased ICP, and 15% had some documented neuropsychological abnormality, and 14% had seizures. Importantly, what they found was that patients who presented with neurologic symptoms were more likely to present with metachronous brain metastasis, had larger brain metastases, and more frequently received surgical resection. They also found that patients who were neurologically symptomatic had worse survival time, and that this was true both if you carried neuropsychological deficits or if you had focal deficits. And they've suggested that perhaps these neurologic deficits be entered into the prognostic schemas that we have these days for looking at patients. If we return to our case, as you recall, the individual presented with alterations in handwriting and word finding difficulty, consistent with the CNS metastases in the left parietal lobe and right cerebellum. And as a neuropsychologist, you must consider lesion location and its association with specific cognitive deficits. And clearly, an individual presenting with a left parietal lesion, assuming this person's right-hand dominant and have a normal distribution of cognitive functions within the brain, you would not be surprised to see expressive language difficulties or perhaps even sensory changes that would lead to abnormalities in right upper extremity motor function and contribute to abnormalities in handwriting. Less well appreciated are the cerebellar contributors to cognitive function. We know that there is a cross connection between the right cerebellum and the left cortical projection areas, and this distribution and this pathway is consistent with decreased right-hand fine motor control, in addition to sensory changes that could be at play here. We've also looked at individuals who had cerebellar lesions and used voxel-based lesion symptom mapping approaches, where we map on the cognitive test results to the lesion location from our MR imaging onto the cerebellum. And we've demonstrated associations between right cerebellar lesions and expressive language abilities, auditory attention, verbal learning and memory, and executive function. In looking at brain metastasis patients broadly, patients who have multiple brain mets, the vast majority of them are presenting with some documented, measurable cognitive impairment. Most commonly, this is in the domains, again, of memory, processing speed, and executive function, which are frequently correlated with aspects of quality of life and are also independent predictors of survival time. Historically, there was a demonstration that there was an association between cognitive function and lesion volume, but not the number of lesions. However, more recent studies have failed to find this association. It was probably, although I think that association is probably real and needs to continue to be considered, but there's an expansion of things that we're considering that may underlie some of the associations between brain tumors and cognitive function. And in this really interesting preclinical experiment coming from Manuel Valiente's lab, just recently published in Cancer Cell, what they demonstrated was that when you implanted a brain metastasis into this mouse model, they observed local field potential abnormalities around that tumor, and that there was this metastasis-dependent functional alteration of the LFP oscillatory activity. Specifically, this means that independent of tumor size, what they are observing is that the brain metastasis itself was causing an alteration in the molecular program that appeared to interfere with neuronal communication. So this is, again, an emerging area of cancer neuroscience where we're discovering this reciprocal relationship between the nervous system and cancer in the nervous system.
Excellent. All right. If we go ahead and advance to the next slide. You guys can hold the pointer, yeah. Excellent. So after the patient's presentation, the decision was made to move forward with treatment. And in this particular case, the decision was made to proceed with radiosurgery to both the right cerebellar and left parietal lobe lesion. At that point, she was transitioned or maintained on her current backbone systemic therapy with endocrine therapy, trastuzumab and pertuzumab. So I'd love to move into a conversation around how those decisions were made, the decision for radiosurgery, and then we'll talk about the systemic therapies.
Perfect. So I'll discuss local therapies now for a bit. As this audience knows, local therapy is very much a key element or the key element for patients with brain metastases, in part because of how effective these treatments are, both radiation and surgery, and also in recognition of how important the functional consequences are of unrelenting brain metastasis growth. Radiation is the backbone for these patients, and in some cases, surgery is also offered microsurgically. In general, surgery is offered for patients with large tumors or symptomatic tumors, where there's effect on key circuits, and also for large tumors where we know radiation just doesn't work quite as well. Many people use a cutoff of 2, 2.5, or 3 centimeters, where we know that the efficacy of focal radiation alone is not adequate. We also know that giving radiation treatment, especially focal radiation treatment, SRS, to larger brain metastases also brings a higher risk of radiation-associated side effects like radiation necrosis. As patients live longer, we also have a growing population of patients where tumors are growing through radiation. So even for small tumors where the success rate is 90 or 95%, as patients live longer with better extracranial control, we have more patients who are living to the point where tumors recur. And in many of those cases, we know that repeat SRS is less effective than potentially removing the tumor and other strategies. And in some cases, also as patients live longer, we have a growing population of patients where an isolated site of disease it can be difficult to distinguish radiographically between radiation necrosis or progressive disease. And in some of those cases, if patients are otherwise controlled, sometimes we have a mandate to make the diagnosis using sampling from biopsy or resection. I will say we have a mandate in this patient population to have a very low complication rate with surgery. These patients have advanced disease. For patients with metastasis resection, they need adjuvant radiation to the cavity, and they often need definitive radiation to additional untreated lesions. And we also know that getting patients complication-free through surgery or radiation is also essential because most of these patients need to get onto systemic therapy. So we need very short treatment interruptions, good surgical recovery, improvement in functional status, so they can tolerate systemic therapy, which often drives their oncologic prognosis. There's a good and mature body of literature for surgery, both from a functional perspective and from a survival perspective, dating back to 1990, where Patchell showed improved survival for patients, albeit with symptomatic tumors, with resection on top of whole brain radiotherapy. This has been validated in multiple randomized studies. I will say that it is essential that patients have good premorbid or preoperative functional status. We know that these patients, for patients with a poor Karnofsky functional score of, let's say, 60 or less, actually do much worse from a survival perspective. So we have to be selective in who we're operating on. And I'll just mention the standard of care for patients with resection is adjuvant, or in some cases neoadjuvant SRS to the cavity. We know that, unsurprisingly, this offers a very high rate of local control. And in modern series, our local control rates with resection of a metastasis plus adjuvant SRS gives us control rates of 95% or better, particularly if radiation is delivered within 30 days of surgery. As Dr. Shih will mention shortly, for patients who get stereotactic radiosurgery, we know that we're not treating other sites of disease, and for patients with presentation of a surgical metastasis, those patients have probably already failed systemic therapy, and so are at very high risk for secondary progression in the CNS. And so it's essential that we also incorporate into these patients' surveillance paradigm regular MRI scans. In our practice, that's every 3 months after radiosurgery or resection of a brain metastasis.
Thank you. So that's a wonderful segue. So what are the radiation therapy options for a case like this where you have limited number of brain metastases, such as this, a right cerebellar lesion? You can treat it with radiosurgery like this patient went through, but historically what we did for decades was actually whole brain radiation therapy. Why would you do that? Well, here are some of the considerations for cranial radiotherapy. The standard of care for best brain penetration for decades before we had systemic therapies that got into the brain at therapeutic doses was radiation. And actually, the technology wasn't there to do better, but we would say, well, whole brain radiation therapy made sense because we were treating the spots that we saw on the scans, and we were treating the spots that we didn't see in the scans, microscopic disease that would pop up, arise with surveillance imaging. But the downside of that is it takes a number of days. You can't give a very high dose to the whole brain in one day, so you're usually talking 2 to 3 courses of treatment, and then there was associated more acute and long-term toxicity that we'll touch on. And then progressively, what we're seeing the field shift to over the last decade or two is stereotactic radiosurgery, focus high-dose radiation to the small spot, the actual lesion at hand. The downside, as you heard, is there's no protection to the rest of the brain. So what exactly are the side effects? Because it'd be good to just sterilize the entire brain if we didn't cause side effects, but unfortunately we do. We have acute side effects. US practitioners see this, fatigue on top of prior therapies possibly, loss of appetite, nausea. Vomiting can happen, but really shouldn't if you're paying attention to your patient for the most part and there isn't any other mechanical obstructive concerns. Headaches are usually fairly minor. Over-the-counter interventions usually work. Skin or scalp redness, hair loss that nowadays should not be permanent anymore, but historically left people with permanent hair loss was affected quality of life significantly. And then neurocognitive effects, as we've already heard. Later effects months out after whole brain radiation therapy, and you can have persistence of fatigue, failure to thrive, and this is a huge quality of life component for patients where, yes, their vitals are good, they can walk into your clinic, but what are they doing when they're home? They're just sitting, laying in bed. They've lost the energy to go out to, engage with family and friends, and that's a big part of quality of life. And historically, if you had brain metastases and you received whole brain radiation, your median survival, all comers, was 6 months. In the breast cancer population, these are a subset of patients that fared the best, so maybe closer to a year. And then what happens now is we're going to hear much more about with new systemic therapies where metastatic disease, even in the brain, is becoming more and more a systemic chronic illness. What we see now is hypopituitarism. If you give the whole brain radiation, you will almost always develop one or more axes of hypopituitarism inevitably leads to fatigue, lethargy again when you get hypothyroid, hypercortisolemic. And this also is another thing that we create but can be fixed. So it's something to monitor in your patients if they're hopefully longer-ish term survivors beyond 6 months and onward. Neurocognitive deficits, unfortunately, tend to be permanent. They're short. They're subacute symptoms at dips, it's worse, but long-term there can be permanent effects, as we've heard, and also high-frequency hearing loss to the cochlea. A lot of these things, I would say, can be affected, reduced with modern whole brain radiation therapy techniques, so you should definitely push your radiation oncologist. And then on the SRS side, typically there should be no side effects if you're treating tiny lesions. The bigger they are, I have a very low threshold to send them to my neurosurgical colleagues because I think nothing really replaces that as a local therapy for mass effect reduction. And again, transient headaches are possible. There's a very low risk of seizures. We do usually provide seizure prophylaxis in areas of the brain where this can be triggered. And late effects, inflammation and necrosis, of course, is something we want to minimize. So as we're transitioning more and more to SRS as a standard of care for acute brain metastases, one of the questions is, well, why bother with whole brain radiation? Is it just from the metastases themselves that are causing these neurocognitive effects? This NCCTG Alliance trial that randomized 200 plus patients between SRS with or without the addition of whole brain radiation therapy specifically had the primary endpoint of neurocognitive function at 3 months. And what they found was, in fact, there was a cognitive decline specifically in the domains of a median delayed recall, so memory, median survival, although the number looks bigger there, was not actually statistically different. So this really pushed us away from doing whole brain. And in addition, there are several studies that look at the equivalence of doing 1 to 3, 1 to 4 brain metastases with SRS alone as being non-inferior to whole brain radiation. There's this prospective registry trial from Japan of over 1,000 patients that show no survival difference if you SRS 2 to 4 brain metastases in blue, which is fairly standard, versus 5 to 10 metastases. And this has largely been an adopted practice, I think, in many places.
Excellent. So that was a beautiful overview of the decision-making and the data behind the decision for this patient to move forward with radiosurgery as a local therapy option. And the other piece that we discussed is that the patient transitioned or maintained on her ovarian suppression, aromatase inhibition, trastuzumab and pertuzumab. So what data drives that? And largely, this is a kind of a data-free zone. We do have guidelines, however, that indicate at first intracranial progression. In the setting of extracranial disease stability, we have the capacity to maintain the backbone therapy. That typically will follow the traditional algorithm of how we manage patients in the HER2-positive space, which we know even from today is rapidly evolving. But it does give us the capacity to maintain backbone therapy, particularly if it's relatively non-toxic. We'll talk a little bit about whether or not we should challenge these guidelines, but at present, these are the guidelines that are placed forward by ASCO. So about a year later, the patient had been undergoing surveillance brain MRIs. We talked about every 3 months in this setting. And we start to see growth of the right cerebellar lesion. That was concerning for either radiation therapy necrosis, it had been a year since therapy, versus progression of disease in these sites. So because there was this controversy, and we'll talk a lot about the challenges with radiographic imaging of determining necrosis versus progression, the decision was made to move forward with a brain biopsy to help guide next best care. And in fact, this did return with recurrent disease, metastatic adenocarcinoma consistent with breast primary. At this point, the estrogen receptor is much lower, 5%, PR is negative, and HER2 remains 3+. So the decision at this point in the setting of second intracranial progression or second event was to transition to the HER2 climb regimen with dacatinib, capecitabine, and trastuzumab. So here you'll see an overview of the tools that we currently have to treat patients with intracranial metastasis based on NCCN guidelines. And I think the font is a little small on the left, but I think one of the things to see here is really remarkable. This is actually across all solid tumors, and this is quite an extensive list. So you think back to where we may have been about 5 years ago, this list would not look as impressive. Many targeted agents for our patients with lung cancer, melanoma, some are tissue agnostic. We're going to focus in here, of course, on the HER2 positive options, and strategies that are currently available in 2023 are in several buckets. One would be our HER2 tyrosine kinase inhibitor bucket, and this includes dacatinib, neratinib, historically lapatinib, as well as pyrotinib. In terms of HER2 targeting ADCs, we hope this list expands, but currently we have TDM1 and trastuzumab deruxtecan. And then there is data illustrating that higher doses of trastuzumab along with pertuzumab have higher CNS pharmacokinetic profile and could be an option as well. So I'm going to turn over to Dr. Dent to walk us through some of the data for the HER2 tyrosine kinase inhibitors specifically.
Thanks so much. I first of all want to thank our fearless leader, Carey Anders, who put together this really quite extraordinary panel. I think we can all agree that more than any area of breast cancer, multidisciplinary care of CNS metastases is essential. Not only do we need our other specialists, but also we need our medical oncology colleagues, because as you astutely pointed out, up until recently, the trials actually did not allow patients to be enrolled that had CNS metastases. And in addition to that, we didn't have any evidence of activity in the CNS, which meant that we really relied on our colleagues and our other specialists. We really focused on local control, but now you actually have a little bit more confidence in us. And I think the pivotal moment really is with the HER2 CLIMB study, where, my radiologists are like, what are you actually giving? Something's finally working in the brain. And, it took our radiologists to tell us, but they were just so sick of saying progression, but now they actually have in their reports, response, and I even have complete response in leptomeningeal disease in one of my reports. I circled it and put it on my wall to keep me going. So I wanted to start with the HER2 CLIMB study because I think, as I said, this was a really pivotal moment where, patients were allowed with CNS metastases and were randomized to, at the time, what was standard, to receive trastuzumab and capecitabine plus or minus the TKI tucatinib. Quite a large number of patients were treated on a 2-to-1 basis, so 400 and 200. Next slide. Oh, sorry. Thought you still had it. So I think what's really important here to look at the landmark analysis, and I think, like I said, this was the first time that, at 1 year, at 2 year, you can see a dramatic separation on those curves, and where patients were alive and doing well, even several years after the diagnosis of CNS metastases, which is now reflected in our clinic, and we'll talk about the case. And then the other thing that was really important is, about 10 or 15 years ago, I was at an advisory board talking about CNS metastases. And one of the things limiting future development of trials is people were saying, it's so hard, patients with CNS mets are so different, and how do we measure, and we'll never get, the outcomes we want. But this trial really showcased that we actually did see this tremendous intracranial response and improvement in PFS. And what you can see here is more than doubling of the intracranial progression-free survival from 4.2 to 9.9 months, which is, when you add all the different compounds we're able to give now in HER2 positive breast cancer, this really was, a watershed moment. The other thing that I think for me really spoke to me was that I thought, okay, well, my radiation doctors have probably, and my surgeons, of course, have done a great job at sort of sterilizing the brain in the lesions that are there. But can we actually prevent these other lesions from growing? Because this is the thing that always made me nervous. It's like you've taken care of a few of these lesions, but what about the rest of the brain? And so this is, again, what was so pivotal is that you looked at new brain lesion-free survival. It's a bit of a mouthful. But basically what you're looking at is, can we prevent these new lesions? And basically you're looking at 13.8 months when you're just giving trastuzumab capecitabine, but you add in the tucatinib, you're getting to more than 2 years where you don't see any new CNS mets. And this is why it's really exciting to see these agents move up to earlier line in our metastatic armamentarium, but also into earlier breast cancer cancer. Again, can we prevent CNS metastases in the first place? And this data would suggest yes. Now, I really want to commend Sarah Sammons and Carey Anders for this Bridget study. And the reason is that, as, you just heard about, the guidelines are really just guidelines. We don't have any data. This is a data-free zone. And so the idea is, when you especially have HER2-positive disease, the data says you give your local therapy, and then you continue the same therapy. I can tell you that's really not reassuring when you're in clinical practice, but it's kind of what you do because that's what the data tells you to do. And so this is why this study is really quite innovative, where they're looking at then giving sort of secondary prevention with either TDM1 and tucatinib, and we heard a little bit about that data earlier today, or trastuzumab, pertuzumab plus tucatinib. So well done, this is a great study.
Excellent, yes, and the Bridget study is currently ongoing. It's about 25% accrued, and I think it's really interesting to see the data this morning for the TDM1 tucatinib, which is also an option in addition to trastuzumab, pertuzumab, and tucatinib. So we're really anxious and eager to see the results to see if we can really expand on that time to next intracranial lesion to protect the unirradiated brain. So we're going to do a change in scenario here. So let's go back to where we were earlier. And instead of having the patient's biopsy return with metastatic disease, radiation therapy necrosis. So here we're seeing growth of the right cerebellar lesion. Again, we always have this question, and I think this is a weekly discussion on the Duke Tumor Board with Dr. Lascola, as to whether or not we're seeing changes related to necrosis or changes related to tumor burden. So the patient presented with ataxia, dizziness related to edema in the cerebellum. The brain biopsy result shows radiation therapy necrosis with no active carcinoma. So I'm going to turn over to Dr. Lascola to describe a little bit about how he guides us in our tumor boards and what he's thinking about when we're trying to make decisions between a diagnosis of radiation therapy necrosis or metastatic disease in this setting.
Guide is charitable. We have not figured out yet how to make a distinction between radiation necrosis and local disease progression in the zone of the lesion that was originally treated. Some cases are more obvious. In the top row here, we have a patient, ER positive, has SRS, and we can see within the isodose line that there's a little bit of central necrosis at 8 months, and then there's progression of the lesion still within that treatment zone with more edema. And this is sort of a classic presentation of radiation necrosis, but I'm going to show some cases on the next slide that will demonstrate that that could easily also be recurrent disease. And then in the bottom row, we have another patient who has undergone SRS, again with a lesion in the left cerebellum. At 9 months, you can see that central necrosis. And then at 12 months, you can see this nodular tissue that's increasing centrally within the lesion. This is more likely, much more likely to be disease progression because you can actually see new tissue. But I can also say that we've seen cases where this comes back as radiation necrosis as well. We could review all the techniques that have been looked at, everything from perfusion imaging to spectroscopy to radiotracer technologies. I would say probably the best accuracy that we've seen in the literature in very small studies is maybe 60–70% accurate. And so we're kind of stuck with one very important question, which I think is, how accurate do we need to be in order to actually have an effective technique that may change management? If you're only 80% accurate, is that going to actually really change how we're approaching this right now? Which is, if we think it might be radiation necrosis, maybe we'll use steroids or maybe some Avastin and see if we can hold on, or maybe send the patient to LIT. What we're dealing with now with radiation necrosis, I think it's really a different entity in some ways from like the necrosis we see with primary tumors. It can be fairly aggressive. It's this auto-propagating inflammatory process that really needs to be treated anyway, regardless, whether it's through LIT or through resection. And so really what we're trying to do is try to decide, is this a patient who should just go to those modalities, or should we maybe try to calm it down first? And so I'm not sure if we're ever going to really have a technique that's going to be all that good to radiographically to make that distinction. I think that's kind of going to be where we end up. Where's the next, the bottom one?
That's okay.
Okay.
There you go.
All right. And this is just, so I showed you kind of a more obvious situation, but this is kind of what we deal with every week. These are 8 different cases. And I'll tell you right now that 4 of them are disease progression and 4 are radiation necrosis. And see if you can figure out which one is which. So the answer is the first 3 on the bottom are actually radiation necrosis in the top right. But I was shown this panoply of slides in a conference without any preparation, and I got every single one wrong. So.
All right,
Excellent.
so of course we would love to prevent radiation necrosis. We'll talk about prevention before treatment. Well, the best way to prevent radiation necrosis is not to have radiation. And that's why you're all here, because we're looking for new systemic therapies, new ways to either prevent disease progression into the brain or to treat it effectively and avoid radiation. But when you do need to use radiation, there are some general principles to help reduce radiation necrosis, which is not an immediate effect. It's 3, 6, 8 or more months later. So you have to know what you're doing, because you don't get to try it today and figure it out if you did the right thing tomorrow. They have to come down to these factors: small volume, don't treat any bigger than you absolutely need to, which is why SRS small lesions are good and resecting big ones is better. So you need to team up and have a great neurosurgical team. You want to use the lowest effective dose. You don't want to use the high dose that everyone says that works just because it works. You want to keep pushing it lower till you find the lowest possible that's effective. Generally, you want to be cautious with concurrent systemic therapies. There are cytotoxic traditional chemotherapies, TKIs, immunotherapies. They've all shown combinations that have exacerbated a radiation inflammatory response, increased necrosis. It's not uniform, so you have to think about it case by case. And if you have a tiny little lesion that you're SRSing, you can get away with 1 or 2. But if you've got if you've got 5 or 6 lesions or large metastases or doing whole brain, then you may want to be a little bit more judicious and space your therapies. Location. Gray matter is more resilient to deep white matter, where we see more brisk inflammatory response. Avoid reirradiation if you get into the same area. And fractionation. As much as patients love single fraction SRS, it's so convenient. When in doubt, fractionation is always safer on the normal tissues. Unfortunately, it's also less effective on the disease, which is why we also have to increase the overall dose. So once you have necrosis, what do we do? Most of you already know this. Steroids is our first go around. I'm not going to go into more details on that, but I'm happy to discuss steroids with anyone. Dexamethasone has a half-life of 36 to 48 hours. You don't give it QID, otherwise they don't sleep, and that's not a good thing for our patients, right? So usually a once a day, twice a day, stay away from bedtime. Bevacizumab is something that you think about jointly with your medical oncologist, your neuro-oncologist. Usually well tolerated, but certainly there are times when you can cause bleeding or clots, and so not to be taken lightly. Surgery, I'm going to defer to Dr. Moss to talk about, as well as LIT, and a few other things that we'll talk about after that, but prevention is always best. So just to touch on an example of bevacizumab, here you can see this case series actually from Memorial Sloan Kettering, I think, where you can see, and we all have these cases. Someone is just very symptomatic, they're obtunded sometimes, you give them 1 dose of bevacizumab, it's like watering your dry flower, and they're perky and talking and walking the very next day. All right.
Perfect, thank you. So I will say, we often tell patients, and it can be hard to believe if you haven't seen it, necrosis can actually behave like a growing tumor. In fact, it can often cause problems more than an active recurrent metastasis. So it's something we do take very, very seriously. And just to add on to Dr. Lascola's point about the difficulty of imaging, it does seem to be a threshold effect. I think one of the biggest problems we have is that, as he said, when these tumors do recur, they're almost always within a bed of necrotic tissue as well. So, and we have a series recently showing specimens with as low as 5% recurrent disease actually have as high a rate of progression subsequent to resection as tumors that are 100% recurrent tissue. And so, and I won't share the difficulty I have with the patient now who we resected completely a tumor 2 months ago. We elected to observe because it was 2% viable, and now they need surgery again next week. So it really is a very big challenge trying to find that small amount of tumor tissue non-invasively and manage them accordingly. In some cases, sometimes patients do require surgery because of mass effect, because these do behave like very aggressive, edematous, inflamed tumors. And sometimes we do have to remove them. As briefly alluded to, dexamethasone has its own set of side effects. It's often not tolerated in patients, for example, who are diabetic, who become manic, they're insomniac. And Avastin, while wonderful for reducing edema, also is a chemotherapy that is quite toxic in many patients. So increasingly, we do have a population of patients who are living many years out from radiation, doing very well from an oncologic perspective, but they do require removal. Surgery does work well, especially if you can keep your complication rate low. And we've shown a very good rate of edema reduction and steroid reduction in patients who undergo resective surgery for palliation. And in some cases, because the imaging is not so good, there are more and more patients where we operate for the purposes of diagnosis. If there's a solitary lesion that's growing, it's enhancing, it's hard to tell what it is. There's often the question mark of whether there's recurrent disease that may warrant a change in systemic therapy or more radiation, for example. And I'll briefly also mention, we were happy to see that subtotal resection can also have a similar effect on edema reduction and steroid requirement reduction, which is important to know because these often expand quite dramatically and can affect what we call eloquent circuitry, important circuitry that cannot be removed. This is an example of a patient who was actually treated with trastuzumab deruxtecan and multiple courses of radiation, both whole brain and SRS. And she required 2 different samplings because we were convinced in panel C that tumor was alive, given how nodular it was hyperperfusing, it was FDG avid. So that location got a biopsy, was not safely removed, or removal didn't make sense at that moment for her, but we did a biopsy and a laser ablation, came back as necrosis. And you can see a very large parietal and also posterior frontal mass that was causing severe mass effect. It was basically making her hemiplegic. She was unable to walk. We removed that area, and that area also showed only radiation necrosis. We do think that in the ADC era, we might actually see an increased rate of radiation necrosis, particularly with concurrent radiation. And in fact, we published a brief report just a few weeks ago showing a much higher rate of radiation necrosis with concurrent SRS plus ADC across the class. And I'll just briefly mention that our armamentarium has recently expanded for minimally invasive percutaneous sampling, so biopsy and laser ablation, what we call LIT, laser interstitial thermal therapy, which is a really nice technique that we perform with an intraoperative MRI scan. It's a hybrid suite where we have operating materials and also the MRI scanner. And basically we make a very small, it's essentially percutaneous, a very tiny incision. We place a probe deep into the brain tissue, we can take our biopsy, and we can thermally ablate under real-time MR thermography, so we can actually map the heat spread within the brain. We're using this very selectively in our institution, really for lesions that are small and deep, and also not immediately adjacent to important circuitry like vision, speech, or movement. And there is encouraging early data showing that this may be effective for reversing the tide of edema. But I will say this is a very large knowledge gap. We don't really even know what the natural history of radiation necrosis is without any treatment. I will say we've had many patients where we have a growing tumor, it's in a sensitive spot, sometimes it's asymptomatic, we'll schedule an MRI scan in 3 weeks and we'll book surgery in 4, and the tumor will disappear, and we cancel surgery delightedly. But I think this is a very important area of continued research.
And then a few other opportunities if you are facing radiation necrosis. This is a medical therapy option. This is taken from the osteoradionecrosis practice that we also create with high-dose radiation, particularly in head and neck cancer patients or coma patients. It's a common regimen using a combination of vitamin E as an antioxidant and pentoxifylline that helps the perfusion through capillaries and small blood vessels to help normalize, not really normalize, they normalize or they make the red blood cells a little more flexible to pass through. And somehow, whether you treat a month, 6 months, a year, there's no standard of care. You just do it until until you get a scan that looks better and a patient feels better, this sometimes works. So it's a fairly safe, low-cost opportunity to consider. And then if you live near somewhere where they offer hyperbaric oxygen chambers, this is another thing that can also be an opportunity. Inconsistent, some patients don't like it because they don't like that feel, because you go in these dive chambers, pressure changes, and it's a little bit like going to radiation treatment where you go for multiple courses of treatment over several weeks. But as you can see in an example on the bottom panel of a case of a patient that was treated, they didn't develop a radiographic and symptomatic radiation necrosis until a year and a half later, and then underwent the hyperbaric oxygen with both clinical and radiographic success. Carey.
Excellent discussion. So lots of information here on the issue of radiation therapy necrosis, diagnostic challenges, and then some treatment options that are really expanding. In our patient's case, we're now a year later, and she has now developed multiple small lesions. These are all sub-centimeter that are amenable to radiosurgery. At this point, she's also developed extracranial disease progression, and so has several lesions in the liver that are consistent with extracranial disease progression. So now we're seeing both concurrent intracranial and extracranial progression, and the decision was made to transition over to trastuzumab deruxtecan at this point. So I'm going to turn over to Dr. Dent to review the data that we currently have with TDXD in this setting.
Thanks so much. So I'm very aware that we probably have a broad audience and also a panel that isn't as familiar with trastuzumab deruxtecan as many of us have come to know. So really the important thing is that this is the next generation of antibody-drug conjugates. So TDM1 was one of the first, but now there are so many antibody-drug conjugates that are out there, and I think there's really some important things to know about why we're getting better. I think one is we're using a payload such as a topo-1 inhibitor, which is a compound that as a breast cancer doctor, it's not part of our usual armamentarium. So patients are getting exposed to a drug they haven't seen before. The other thing is that the high drug to antibody ratio, it's more than double. And so, we're actually getting more drug in. And I think the other thing that we haven't really chatted a lot about is the bystander effect, and is, why are these large molecules getting into the CNS? And is it maybe this bystander effect that we're hitting surrounding tissue, sterilizing it, and perhaps this is why these agents are actually helpful in actually preventing new CNS metastases. And then I think what's really, really sort of interesting is all these new ADCs, this sort of secret ingredient to their stable linker payload and these linker technologies, which are really quite exciting. So I think you've probably heard the term DESTINY now, which is the series of studies with TDXD. And this was a phase 3 study of TDXD looking at quite a large number of patients, over 500 patients that were randomized to receive TDXD, which is given intravenously every 3 weeks, versus TDM1, which was standard of care at this particular time after patients had progressed on a taxane and trastuzumab and could also have had pertuzumab. And what was unique, and what you're seeing more and more in these trials, is that 20% of patients in each arm actually had a history of CNS metastases. And again, because these patients were typically excluded, this was so important to all of us in our daily practice, and the primary endpoint was progression-free survival. Now, normally our lung cancer doctors brag about their lovely Kaplan-Meier curves and how they separate immediately and they're deep and wide. And so we're really excited for the first time, not only just in breast cancer, but in patients with brain metastases. So what you can see there is brain metastases at baseline. We can see an improvement from 3 months in TDM1 to 15 months with TDXD. And at the 12-month PFS mark, we're seeing 20% with TDM1 versus 72% in TDXD, and hazard ratio of 0.25. So this is, you can see those curves are just immediately separating. So clearly this drug is getting into the CNS. Now what you can see is patients who don't have brain mets at baseline, 7.1 months with TDM1, and they actually haven't even reached PFS, median PFS in the TDXD arm, and a hazard ratio of 0.3. So this was actually a pooled analysis that Sarah Hurwitz recently presented at ESMO, and I think it's really a fantastic use of the available literature to give us a sense of what's happening across these different studies, because the patients are actually going to be quite different depending on what they've been exposed to, could change the natural history under the selective pressure of different treatments. So pool 1 were patients that were on sort of the first study looking at T-DXd, and so were heavily pretreated, and they all just got T-DXd. Then there was the second study that looked at T-DXd versus trastuzumab cape or lapatinib cape, which again, patients needed to have had pertuzumab, trastuzumab, and T-DM1 prior to that. And then the third study was looking at T-DXd versus T-DM1. And so the language that I want you to remember, which is really important when we look at the data, is that we have this TDX sort of brain mets pool and then non-brain mets pool, and the comparator is really looking at whether they got T-DM1 or they got trastuzumab plus chemotherapy. So this is really quite dramatic. So what you want to focus here is, if you look at the T-DXd brain mets pool, whether you had treated or untreated active disease, 45% response in brain. So it didn't matter whether you had it treated or untreated, almost 50% response, which we just never seen before. Now contrast that to the comparator arms, where you see 27% in the treated stable, but really not much activity in the untreated. So it really is quite dramatic when you pool this data together, as my lung cancer doctor said when we presented this a few weeks ago. All right, you're right, that works in the brain. So that was all I had to hear. And so again, this is just sort of highlighting those responses. And I think the other thing that's important is that historically in breast cancer, we get drugs to work, we get a response, but we can't sustain it. And that's really what's so frustrating. We see patients who are like, oh yay, we got a response, and like literally before you do your next scan, things have already progressed. And so I think the duration of response here is really what's quite dramatic, again, with both the treated and the untreated CNS metastases. And then we all like kind of showing off these plots, because again, we just don't see this usually in the CNS, never mind in breast cancer. And you can see in the comparator arm, you see some responses, but in T-DXd, it's a deep, really response in the CNS. And again, whereas in the comparator pool, you just saw a much less of a response in the CNS. Now, these are just some exploratory analyses, and I think, to be honest, they just kind of continue to highlight in this untreated active brain metastases, you're seeing quite a dramatic response. And why this is so important, especially if you think about the case that we just discussed, is that historically, someone had new CNS mets. I'd be on the phone, are we gonna cut these, or are we gonna radiate them? And now, you know, we sort of take a deep breath and we watch and we say, okay, we're gonna be brave, we're gonna sort of potentially go on to systemic therapy, which many of the guidelines now recommend that we can do. And this is actually very different than what we've done previously. And I think this is really important because patients are going to live for a really long time, and we want to avoid toxicity, and this is potentially how we can do that. And so, you know, again, just highlighting the activity in active brain metastases. Now, this is a small study. It's only 15 patients. The Tuxedo trial, you won't forget that. We want to thank our colleagues, Rupert Barsh, for doing this, because I think it really, again, highlights the body of literature that is emerging in active brain metastases. And I think it will be difficult to do another randomized study because people will not want to be randomized to the control arm. And again, you can see those waterfall plots and median progression-free survival of 14 months. Oh, and then the response rate of 73% in brain is really just, again, quite dramatic. And then what I like about this study is looking at the preclinical work. So you've all heard a lot about HER2 low. So what this preclinical work suggests is that it's not just in the so typical 3+ IHC. So even in the HER2 low group, there seems to be CNS activity. And this small series does show us that the in-brain response was 73%. And again, this is in line with the recently sort of presented data on the HER2 low study, suggesting that this compound in the HER2 low patients is similarly active. And so for me, this really does suggest that this bystander effect is critical in having this impact.
Excellent. So lots of data, growing data for T-DXd in both stable and untreated brain metastasis. So here, the patient was maintained on T-DXd for around 20 months, very consistent with what we've seen in the literature. But unfortunately, resistance did emerge, and I think that's a whole nother discussion of what could those resistance mechanisms have been. but there was continued intracranial and extracranial progression. We saw sort of this innumerable miliary lesion throughout the cerebral and cerebellar hemispheres, new lesions in the liver, growth of existing lesions. So in terms of radiation therapy options, there was a consideration for whole brain radiation therapy, and we've talked a lot about why we might not do radiation therapy, but there still is a role, whole brain radiation therapy, but there still is a role in select cases. So I'm going to turn over to Dr. Shih to talk about how the management of whole brain radiation therapy has evolved as our patients are living longer and we're learning more about the neurocognitive sequelae of whole brain radiation therapy.
Thank you. So yes, when we go back to the Aoyama randomized trial, this is 1 to 4 brain metastases, SRS, with or without whole brain. As you can see on the left there, any brain recurrence, ultimately most of these patients are going to develop new brain metastases, and you do get more if it's SRS. Whole brain does do some form of sterilization, either of micrometastasis or makes the brain less favorable for new metastases to grow. It's a little bit lower there. And likewise, local control on the right. I think these curves nowadays, to be repeated, probably be a little bit different. I think we're probably a little bit better in SRS technique. We have a bit more durable local control, as Dr. Moss already showed us, but this is an older study from 2006 that showed that whole brain radiation still was cleaning up a little bit of the surrounding, probably microscopic disease. If we go back to the study that I already showed you, where we're questioning the role of whole brain added to SRS, and we were worried because we did show that there were neurocognitive effects with regards to memory function. When we look at some of the other endpoints, it's important to note that no, there wasn't a difference in overall survival because we salvaged therapy of patients who progressed or recurred. But on the right, you see the cumulative incidence of intracranial progression. So as SRS alone, the darker line on top, 50% of people will continue to develop new brain metastases. And then if you add in the whole brain radiation, you significantly reduce that by more than 50%. So that is the rationale for giving whole brain radiation, which is the lesser evil to some extent. But not all whole brain radiation therapy is alike. We've had some nuances over the years to help reduce toxicity, and that's really the goal of the newer generation whole brain radiation. We're not controlling more disease, we're just trying to make it less toxic. The first is introducing memantine, an NMDA receptor channel blocker that's used in dementia. Helps the hypothesis or mechanism of action is reducing vascular toxicity. In the RTOG 0614 prospective randomized trial between patients who received standard whole brain radiation with or without memantine randomized to placebo, you can see in the graph there the reduction of cognitive failure defined by some neurocognitive tests is reduced with memantine. Now this is not a flat line, that's still a line that goes up. It just doesn't go quite as high as placebo. So it's a little bit better than nothing, but of course this is not the result. We're not done with what we need to do. An additional advent in radiation technology is IMRT or VMAT. This is an intensely modulated radiation therapy. This allows us to create creative clouds of three-dimensional doses of radiation with little holes there. Those are the hippocampi. So you can actually make what we call cold spots, low dose radiation in areas where, in this case, stem cells you want to help preserve because we think they're important to maintenance or regeneration of cognitive function. This was initially a single-arm study in RTOG 0933 compared to historic controls. These patients had less decline compared to historic controls. These patients had less decline in neurocognitive function at 4 months following whole brain radiation, but that was enough of a data to fuel the NRG CC001, which defines our now standard of care of how we do whole brain radiation. Again, over 500 patients randomized between hippocampal avoidance or standard whole brain radiation in neurocognitive function at 4 months following whole brain radiation, but that was enough of a data to fuel the NRG CC001, which defines our now standard of care of how we do whole brain radiation. Again, over 500 patients randomized between hippocampal avoidance or standard whole brain radiation, where the entire brain gets the same dose, and both arms have memantine. Again, you see with the hippocampal avoidance, you have a reduction, but you don't have prevention of neurocognitive failure.
So the important thing, I think, of these studies, from my point of view, is that they are proof of principle that we can actually make a difference. So for a long time, there was a lot of therapeutic nihilism around being able to protect the brain and prevent cognitive dysfunction, or potentially to even restore cognitive function. And I give a lot of credit to radiation oncology for leading the way and integrating cognitive endpoints into their studies, kind of challenging their therapies, challenging themselves to do better. I challenge medical oncology to now introduce neurocognitive endpoints into their studies to see if we can differentiate therapies on the basis of toxicity as well as survival time. With regards to radiation therapy, I think if you look at this timeline here that has been published before, which shows the types of neurodegenerative processes that radiation causes, you'll see that many of these are developed or initiated very, very early in the course of treatment, within hours, days, or weeks of treatment. And I think that our approaches to mitigating these also need to be early. So it's not been very effective, if you look at studies in the literature, to introduce a neuroprotectant or to try to restore cognitive function a year after having received radiation therapy. It's probably a better idea to get this going early. There are a number of ongoing clinical trials, some of which are using radiation therapy techniques, again, adjusting dosing, targeting different things, using different technologies to adjust how radiation is delivered. And there are some novel pharmacotherapies as well. So there's more in the works. As Dr. Shih mentioned, this was proof of principle. This is a start, but this shouldn't be where we end. And this is my kind of boxy schema of how I think of cognitive enhancement strategies. We have prevention approaches. You've heard about these, using stereotactic radiosurgery, hippocampal avoidant whole brain radiation therapy. And we have neuroprotective strategies like using memantine during whole brain radiation therapy. When I think of the lane down the middle, this is oftentimes where more work has been done for neuropsychologists. You could look at these pharmacologic interventions to include memantine, but also things like psychostimulants, methylphenidates, and things such as that, and I'll show you the kind of reviews on the efficacy of that for radiation-treated patients. There's growing interest in neuromodulation strategies, things like transcranial magnetic stimulation as a potential therapeutic avenue, though there have been no trials that have demonstrated the benefit from this. And then there are kind of the classic behavioral interventions. There's a lot of interest in exercise as medicine. We know that cancer patients are not moving as much as they could. We know that there's evidence that movement and physical activity can improve brain health, but we've really struggled to demonstrate that that translates into improvements in cognitive function. We know that sleep is often disordered in our patients, and that correcting those sleep deficits may also have positive effects on cognition. And then there's kind of the sweet spot for neuropsychology, which is cognitive training, that can then be broken out into restorative approaches. And you may hear of like packages of cognitive exercises that people are doing repetitively that doesn't seem to generalize to everyday life, or the more classic compensatory or adaptive rehabilitation strategy approaches, which are frequently the ones that we rely on in our clinical practice most. So a recent Cochrane review of cognitive enhancement strategies for patients who have been treated with radiation therapy concluded that there were a lot of methodological weaknesses in the rehabilitation literature, generally small sample sizes, challenging randomization and blinding, limiting evidence that supports efficacy. In that context, when they compared two different psychostimulants, methylphenidate with modafinil, they found that methylphenidate seemed to be more active in managing cognitive difficulties, as well as fatigue and sleep disturbance. There was a study looking at donepezil to try to mitigate cognitive dysfunction, and when that was compared to placebo, there was not a significant benefit from donepezil. This is a classic example of the timing, though. In this particular study, this was done, patients were introduced to donepezil or placebo quite a long time after completing radiation therapy. Then there is behavioral approaches. So there's been the study of goal management training, which is a cognitive rehabilitation approach to improving executive function. And when compared to a waitlist control, there was no difference in terms of cognitive or quality of life outcomes, which oftentimes leaves us with good medical practice, right? Looking for comorbidities, potential reversible contributors to cognitive dysfunction, to include things that probably are well known to this audience: metabolic abnormalities, medication side effects, minimizing medications with anticholinergic properties, thinking about pain medications and their contribution, and thinking about substance use or abuse. And this is not always intentional on the part of the patient. The patient may have a memory disorder and not be taking their medications as directed, and that may be mitigated just by using pill box, alarms, or caregiver support. As we'll talk about, fatigue is very, very common. Addressing that can oftentimes improve all aspects of quality of life. And we often discuss with patients general brain health approaches to healthy diets, exercise, stress management, social engagement, and proper sleep. Cancer-related fatigue has been defined by the NCCN as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer that is not proportional to recent activity and interferes with usual functioning. And the graph that you see here shows that fatigue in all forms of severity is perhaps the most common symptom that our cancer patients are experiencing, more so than nausea, depression, and pain even. There are a lot of things we can do to help mitigate fatigue. Some of those include identifying and treating underlying medical comorbidities that are correctable. Regular exercise and sensible diet seems to be helpful. And then activity scheduling and energy conservation is a psychotherapeutic technique that we introduce to our patients who are struggling with this. Again, monitoring sleep, talking about sleep, and sometimes using stimulants can be helpful. Sleep disturbance sometimes arises just out of poor sleep hygiene, and giving patients skill sets around sleep hygiene can be helpful. There can also be timing of medications that could be driving this sleep disturbance. We've already heard this mentioned a couple of times with regards to steroids. And then ultimately they may benefit from a sleep study that may identify sleep architecture problems that could be correctable. There was a study that looked at psychostimulants versus cognitive behavioral therapy for insomnia and fatigue. And this path diagram summarizes this data. And what this data showed was that there was a direct benefit from cognitive behavioral therapy addressing these sleep hygiene abnormalities that led to improvements in fatigue. And there was not a significant effect of stimulant in this particular study. There's been studies examining medical Qigong, which demonstrated that there was a reduction in cognitive concerns, subjectively reported cognitive complaints, and improvements in CRP levels. And yoga for cancer survivors, when delivered in 8 75-minute instructor-led sessions 2 times per week, largely in breast cancer survivors, demonstrated reductions in cognitive complaints, and that this improvement in cognitive complaints seemed to be mediated by improvements in sleep. So once again, the central issue here being sleep fatigue, oftentimes driving these cognitive concerns, and that these are addressable and oftentimes modifiable and should be targets in our clinical practice. As I mentioned, many of our cancer patients are not exercising up to the recommended 150 plus minutes of physical activity a week, and more than 50% of patients report no moderate or physical activity. And what the graph on the left is showing you is that as you move from left to right and you have increasingly less physical activity, the risk of dying increases. We know from animal studies that exercise is associated with hippocampal neurogenesis and positive effects on brain and cognition. As I said, this has not yet translated into our ability to find this in human studies. But the American College of Sports Medicine has recommended a kind of dosing schedule, if you wish, for exercise that can have positive benefits on a lot of different aspects of life, not just cognition, but mood, fatigue, general quality of life. And a small pilot study performed in the Netherlands by Karen Gering in primary brain tumor survivors demonstrated that exercise led to improvements in attention function. So maybe there is some promise and some hope yet on the way for that.
That was really helpful. I think a lot of the doctors need to get some more exercise as well, even though the gym was quite full this morning. But the recent data on activating the immune system and exercise, if you could market that, would make a lot of money. So we'll all have to work on that. So before we've got, Dr. Anders has some questions coming through, and we've got another small, short, triple negative case, but get your questions ready, because I'm sure all of you have been burning with some questions to ask our panel. So just a few slides before we get there. So there's some really great data studies coming out of the TBCRC. One is looking at TDM1 and neratinib, and I think, dual blockade, whether through TKIs and anti-ADCs or dual antibodies, there's a lot of studies looking at trying to overcome resistance. There's also some really exciting new compounds and trials looking at CAR T cells. There's a compound ZN1041, and then I think we're going to talk about in a moment that, this genomically guided clinical trial, I don't typically do a lot of brain biopsies, but I think this idea of really sort of doing precision medicine for CNS mets is important to biologically understand whether they're different or not, but also try to come up with some, more tailored therapies. And there are many trials ongoing, and I think it's a testament to the, I would say, tenacity of investigators around the world and the bravery of the patients. This is really just to highlight one of the studies that the TBCRC is doing, and again, they've been sort of pioneers in trying to get these studies done. And so this is looking at neratinib, another TKI that, I think, is there, and I think we can't forget about the other agents. And this is looking at in combination with TDM1. And what you can see here is that unfortunately this study has been terminated early due to slow recruitment, and that's really just because there are so many compounds that are out there. But I think it really does highlight that this is potentially a compound that can overcome resistance. And you can look in the sort of circles, there does seem to be some activity even in patients that have been had prior whole brain RT and as well as SRS. And again, this is just to highlight the intracranial activity that was seen in all of the cohorts, including patients with prior TDM1 exposure. Again, highlighting, can this particular compound, neratinib, overcome resistance? And I think this is such an understudied area. Why do patients become resistant? How do you overcome that resistance? And the idea would be to sequence the patients with these exquisite responders and then these patients that are resistant to try to tease this out a little more. And as you can see there, there were responses around 30%. Diarrhea is something that we've become quite used to treating, and we can manage that pretty easily in our clinical practice. And again, I won't go into detail, but what's interesting about this study, and I think we're hearing a lot about this at the meeting, is that a lot of the new studies are tumor agnostic, right? So we know that there are similarities. We've seen data with TDXD in the lung population. And so what we're seeing here is looking at really a biomarker-driven study where they're looking at alterations across the spectrum, and you can see the bottom is looking at KRAS. And I think, we're really excited to see as these trials progress, but also the bravery, again, of the patients. So with that, I will hand you back to Carey.
Great. Okay, so we're going to pause for a moment before we go into case number 2. We're doing great on time, so thank you to my speakers. And we've been doing a lot of talking, so we want to hear from you. We are getting some great questions from the virtual audience, so I thought we could start there, kind of see how much time we have, and then we'll leave the last 20 minutes for our last case. So one of the first questions, and I'm going to direct this one to Dr. Moss since he was part of this study team, is for patients who are on an ADC, what is the appropriate washout period prior to radiosurgery to avoid necrosis or after radiosurgery?
Yeah, so in that brief report that just came out, we showed that the washout was we didn't want ADC 1 week before. We defined ADC within 1 week before and 1 month after SRS. Mm-hmm. It is a small study, so we definitely need more data, but I think it's prudent probably to wait a month before and after at this point.
Yeah, no, absolutely. And I think this data came out just, 2 or 3 weeks ago, and I'm already using it in my practice. So kind of having that and it works well with a Q3 week dosed drug, mm-hmm. because you can give a dose mid-cycle, go ahead and do your radiosurgery, and then wait 3 weeks later to dose again. I think it was 21 days, 28 days, 21 days?
It was 28 days for the day.
On either side. And then so the patient is, particularly if they have concurrent competing extracranial disease, you're not delaying much, but decreasing the rates of radiation therapy necrosis, I think from 42% to 9%. Yeah. So really remarkable decrease.
I might just add that many of those patients were accrued or observed at least before the data came out for TDXD. And so I think,
interesting.
Increasingly as we're seeing, CNS effect, I think we can be maybe a bit more brave in treating with, systemically alone.
Yeah, excellent. The other question that I will direct toward Dr. Dent is, when you're using bevacizumab, what's your preferred regimen and what is your preferred dose? And I know that's a loaded question. So
No, actually, I was showing off these pictures earlier because I think for quite some time, we've had this issue of radiation necrosis. Patients have been suffering, or they have a lot of chronic edema from their radiation. And so many years ago, we started giving, bevacizumab. It went off patent, so it wasn't expensive. Now, outside of the US, I think or inside the US, you have a bit of an issue, but outside the US, it's not as big an issue. But it's quite dramatic. So we typically give 5 milligrams per kilogram every 3 weeks, which is, just a dose to reduce the inflammation. Now, if I have someone who is quite acute, like the patient you described, then I want to give them 7.5 milligrams per kg. And then, depending on what their their responses and what the edema is like, then I might continue it every 3 weeks for a couple of cycles. But one of the things that I do is, you know, a lot of patients can't be on chronic, well, nobody wants to get chronic steroids, you know, that stops working. But in my patients who are living a long time where they have this chronic edema and they actually get headaches, you know, the headaches come back. And so I just give them like every 6 weeks, a little bit of Bev every, you know, 5 milligrams per kg. And it seems to be just enough to control their symptoms. So I'm not using it as a therapeutic intent to sort of, you know, treat their tumor, but to control their symptoms. And really the side effects can do, because we were talking about that, but at this small dose, I'll be honest, the patients tolerate it extremely well. So that's my approach. Not sure what you think.
No, absolutely. And I think a lot of times it also depends on what systemic therapy the patient is currently on. I think one challenge we have, and actually the NIDIS for a retrospective study we're working on, is what is the safety of bevacizumab with many of our newer agents? And the answer is we really don't know. So I think collecting this collective experience from others to really see, are there increased risk? But I also agree with the lower dose is perfectly fine. We've seen doses as low as 1.5 milligrams per kilogram, 5 milligrams per kilogram. So we're not in the space where we're giving 15 milligrams per kilogram. So excellent. Why don't we turn to the microphone?
Thank you so much. My name is Eva Schumacher from Germany. I really love this interdisciplinary panel, so thanks a lot. One of the most discussed questions, I think, is screening or not. So I would really appreciate from you having from each one of you one sentence, screening yes or no for brain mets, early or metastatic disease, subtype related, and just one sentence, because I think this is what we discuss up and down. And maybe one short sentence about your experience with minimal invasive biopsies. Thank you so much.
Sure, thank you. So just to summarize, your first question is, what is our stance on screening MRIs? And you want us to all, you want us to...
In non-symptomatic patients.
One sentence, excellent.
Yeah.
And then the second one was around the feasibility of biopsy. Excellent.
Minimal invasive, without like making big holes in the head.
Minimally invasive biopsy. Excellent. Thank you. It's a little difficult to hear. All right. So why don't we start at the end of the table on the MRI screening question?
I defer to my physician colleagues.
Excellent. It was one sentence.
I don't know if I'll get one sentence, but it's not standard of care up front for breast cancer patients the way it is for melanoma and lung cancer. But I think if for suspicion, if there's a clinical component where you're worried about it, we get it.
I agree. I would say, you know, the data in breast cancer is that there's just a really long latency in most breast cancer subtypes to development of brain mets. We just know that they're dormant for a very long time before they actually trigger, and so it's very difficult. And you know, unfortunately, we're hampered. I think there was a study from the Netherlands 15 years ago that showed that there was no advantage in survival. Of course, that's in the old era medically, and even from a radiation perspective. I think we all agree now that we have very effective brain strategies, and so we just need the data to catch up with us and say survival warrants it. I think it would be wonderful if we could develop a high-risk population where we know that the risk is just higher. The problem is justifying to insurance companies a Q3-month paradigm, which is the time frame in which these develop, in patients who are maybe living 10 years on HP. So you can imagine a brain MRI scan, unfortunately, is very expensive, and I'm dreaming of the day when we have, you know, a $10 breast cancer PSA with patients who are getting surveillance MRI scans, and finally we can just develop, you know, if we find something on liquid biopsy, then we screen the brain.
I don't have too much to add here. We're happy to read the scans. I would say that probably just in our experience, the initial scan, not in the follow-up 3-month sort of interval paradigm, but the initial scan, most of these are negative when they come through. So it's still kind of a high sensitivity, or low specificity kind of situation.
So I guess I'm on the hot seat. So I think you have a great question, and I think you'll find that oncologists are very divided on this subject, which is why you're probably sort of really struggling with it. The truth of the matter is, my own practice, I don't screen. A lot of my patients are going on trial, and so they are actually getting it for trial, which seems a bit strange, right? You're going to go on a trial and you get a scan, but we need to know. And I think I agree, historically the data showed us that it didn't make a difference, which I think explains the sort of variability in presentation and latency. And actually our neurocognitive expert actually could weigh in, because this is one of the things that we struggle with, right? Because if you do intervene with surgery or radiation, you potentially could have some so even though you think you're doing well and you found it early, you potentially could actually decrease quality of life and cognitive function, which is so important for our patients. So to be honest with you, I really struggle with it, but I have a very low threshold. So my TNBC, HER2 positive, that have a high burden of disease especially, I have a very low threshold to check. So that's my honest answer. But I'll be honest, the patients that come in to see me for second opinions, some places they just routinely send them through. And so that's when it gets difficult, because I can't tell them that would have made a difference, because we don't know. And so there are ongoing trials now that are actually looking at this question. So the near future, I think, will give us some more information in view of the fact that maybe if we're giving some of these systemic therapies that have CNS penetration, especially in the early breast cancer setting, maybe there might be a difference to screening earlier, because we were talking about doing a trial of surgery with no radiation if we have good systemic therapies.
Excellent. No, that was fantastic, and I would say very much in line with my practice. I do not routinely do screening brain MRIs in the absence of symptoms. I do consider it in high-risk populations, and am very careful to screen for these subtle neurocognitive changes amongst our patients. Very difficult to tease out, right? Regardless of whether or not there's an intracranial lesion present, they've had prior therapies that might have impacted their cognition. So I am awaiting the prospective studies. I would also love to just echo what Dr. Moss said, is that it would be wonderful to have a biomarker or a signature that would help guide us here. And there is some work here in the poster session looking at some of the features in primary tumors that could predict for CNS metastasis. I think that's really what we need. And then I will just turn over to Dr. Moss to comment on the minimally invasive biopsy. And then we'll take one more question and get back to the case.
I'll just make one last comment on that last point. On a human level, if my wife or my sister, God forbid, had breast cancer, I would encourage her to have a headache every 3 months. It's very difficult when guidelines just don't match up. And patients are furious. They come to us, how did we miss this? Why are we presenting at 3 centimeters? As far as the biopsy, these are very safe and very effective. These are being done on an outpatient basis. Envision, 1.5 centimeter incision, takes us 30 minutes. Complication rate is 1% for symptomatic hemorrhage, 3% for radiographic hemorrhage. So these are very straightforward. We almost never do them because it doesn't change management usually. The time we often do them is if there's a question of necrosis or recurrence. In those cases, we often do a laser ablation while we're at it if we're really concerned.
Excellent. One more question?
Sorry,
Oh,
and
yeah,
one last comment. I think maybe an interesting space for this actually is maybe HER2 discordance in the era of HER2 zero versus HER2 low treatment efficacy. There's a paper that we recently published, and I think there's 2 talks later at this meeting talking about a very high rate of conversion from HER2 zero to HER2 low expression, which in the CNS only setting might warrant more and more biopsies.
Excellent session. Thank you for putting this together. Sailaja Kamaraju from Medical College of Wisconsin. I have a quick question. In the era of checkpoint inhibitors, whether it is in the breast cancer or across solid tumors, we are seeing rapid and incredible response rates with immunotherapy agents, even in the intracranial compartment. There are preliminary studies showing that checkpoint inhibitors have some efficacy in the intracranial department also, like whether leptomeningeal disease or intracranial metastases. I was wondering if you comment on your experience on CNS penetrance with immunotherapies, either alone or with radiosurgery or with other combination treatments. Thank you.
Yeah, I'll let you go ahead.
We'll both comment. I mean, I think the bottom line is what we learned from our lung colleagues, and I used to treat melanoma, is that the closer you were from radiation to immunotherapy, the better the patients seemed to do. And so we do think that there's some synergy, and I think there are some, ongoing trials. And I think we just don't know for now, but I think I agree with you. I think it's quite reassuring. And I think the next case you'll find interesting, we talk about leptomeninges, and that still, I think, is a very unmet need and a very challenging group of patients to treat.
Thank you.
No, I think it's actually quite shocking how little data we have in this space. I think when you look back at many of our studies looking at immunotherapy, particularly in the triple negative space, there were very few. I mean, you could count on one hand patients with CNS metastasis enrolled, if any. So I think there are ongoing trials right now looking at concurrent immunotherapy with radiation therapy. We'll talk about one in the next session, but I think we need more data here, and I would just encourage more clinical trials in this space. And actually, I'm going to give time for one more question. I recognize a friend.
Thank you. First of all, thank you for the panel. And I appreciate your honesty about saying that if it was your wife or daughter, because I'm a patient with brain mets, and I think if you ask, well, I know if you ask the advocate community, we really want screening, and not every quarter, but like once a year. But my question is risk-benefit for biopsies with seeding of the brain from the biopsy itself. What do you think of that? And
great question. Yeah.
So it's interesting you ask. We actually last year put out a report on our historical rate of seeding with biopsy, and it turns out the rate of, and specifically we're now mostly doing our biopsy for active disease with LIT. We showed something like a 50% tracked seeding rate. And the Duke group actually recently published on this as well. There is, I think, the brain met biopsy paradigm is unusual. We often biopsy for gliomas or lymphoma, and those patients get wide field radiation, but we don't do that for Mets. But we do think there's a role now maybe for talking about irradiating the tract as well. Versus hopefully the systemic therapies will continue to help us here.
Excellent. Wonderful Q&A. Well, so interestingly, the other questions from our virtual participants are largely around triple negative disease and leptomeningeal disease, which is actually the topic of our next case. So we'll move on into case 2 to conclude the session. So this is a 42-year-old patient diagnosed with a clinical T2N1 triple negative breast cancer who was treated with our standard neoadjuvant chemotherapy immunotherapy protocol. She did have residual disease at the time of surgery, and after her local therapy was completed, she went forward with her pembrolizumab to complete a year of therapy, 6 months of adjuvant capecitabine, and was followed by surveillance. Just to note, her genetics did not reveal a germline mutation in either BRCA, PALB2, or any other inherited genetic alteration. So 9 months later, she presents back to the clinic during surveillance with headache, nausea, and cough. Her imaging reveals both intracranial and extracranial recurrence. We tend to see, particularly in the triple negative space, CNS disease and extracranial disease recurring about 80% of the time simultaneously, very different than what we see in the HER2 positive space. And her CNS imaging reveals radiographic features of leptomeningeal disease. A lumbar puncture is performed and her cytology is positive for adenocarcinoma. The opening pressure was mildly elevated. In addition, she had a bronchoscopic biopsy of a mediastinal lymph node, largely to confirm receptors and to look at PD-L1 status, which was positive at 20%. So I'm going to turn over to Dr. Lascola again to talk with us a bit about some of the challenges of evaluating leptomeningeal disease radiographically and some of the different ways that we can think about LMD, because it turns out it's not all created equally.
Okay, so I think the best I can do here, or the most helpful thing I can do is sort of provide a sort of an anatomical view of what leptomeningeal disease is, because I think that there's a lot of confusion, not only in everyday practice, but also in the literature about what is diffuse disease, what is local disease, what is nodular, what is actually leptomeningeal. So first of all, the meninges are basically made up of 3 layers. There's now rumored to be a 4th, but that's the dura mater, the arachnoid, which is a very impermeable layer, and then the pia mater, and then there's structures in between. And so when we talk about meninges, we're talking about those 3 layers. When we're talking about leptomeninges, we're talking about pia and arachnoid. And so what we see sometimes is this tendency to talk about dural lesions as leptomeningeal disease, and that's not true. They're dural lesions, they're not leptomeningeal. And I think that that really has a big impact also on what we're thinking about in terms of systemic or radiation therapy as well. And so you can see local or diffuse leptomeningeal disease. Here's an example of just a little bit of subarachnoid enhancement, in this case above, and then this more classic pattern of enhancement throughout the sulci of the cerebellum and then supratentorially as well. You know, breast cancer meningeal carcinomatosis tends to be more basilar, but we do see it in the supratentorial compartment as well. And when we have diffuse disease, we're also seeing, we will also see nerve root enhancement. You'll see areas of enhancement that are extraaxial, like involving the pituitary, along the basilar cisterns. And then, because it's in that space between the pia and the arachnoid, in that subarachnoid space, which is basically a superhighway that communicates with the ventricular system, it also communicates with the CSF into the spine, you're going to see areas of spread in the spine often when you see intracranial disease like this. And it can be nodular, it can be linear, it can be diffuse, it could be local, but it's not dural disease in the spine, it's leptomeningeal disease. And so I think the thing to do is to separate those two areas of disease in your mind, because they do have big complications. One of the papers that just came out a few years ago brought up this concept of nodular leptomeningeal disease, which I think has been very confusing. And I've been asked a lot of questions about this clinically every week, you know, is this nodular or not? And I don't think that's the right question. In this particular case of nodular leptomeningeal disease that they were talking about, they were talking about the scenario of a post-resection, post-stereotactic radiosurgery, post-resection situations where there's local recurrence that's thought to be related to seeding at the time of surgery. But you can see that these lesions are actually dural-based. They're not leptomeningeal. And so I think it's a misnomer to use the term nodular leptomeningeal in this case. So I would think about it as dura and leptomeningeal.
Excellent. And as we transition over to Dr. Moss to talk about how we think about CSF diversion in the setting of leptomeningeal disease, you know, one thing the panel was discussing prior to our session today was the fact that we are increasingly seeing leptomeningeal disease or suggestion of on radiographic reports of MRIs, because neuroradiology has gotten a lot better. But the problem is many times that can exclude a patient from a clinical trial. So I think this distinction is so important, and in fact some of the trials are now saying, you know, discrete dural-based metastasis are allowed. So I think that's really important as we're interpreting data in this space. So as a medical oncologist, one of the things I'm always concerned about is whether or not the patient has a structural abnormality that I need to call in my local therapy friends to help me with before we move forward with therapy. And so I wanted to turn over to Dr. Moss to talk a bit about his thought process about when to consider shunting in this space.
Thank you. And I just to emphasize Dr. Lascola's point on terminology being essential, I think all of us on the care team have a really important role to play in terms of making sure that the diagnosis is made correctly, because I can share a brief example just highlighting, you know, we had a patient with a cystic tumor, small specimen in the brain. We sent the cyst fluid. It was mislabeled by the operating staff as ventricular CSF, came back positive, and the insurance company refused to allow further treatment. Actually, in that patient, 3 rounds of appeals, and it ended up being very difficult for the patient. And so I think we all have a mandate to making sure that this term is not thrown around loosely. To change gears and just discuss quickly, you know, leptomeningeal metastasis is very scary in part because of the prognosis that it confers, but I will also say that it is symptomatically often one of the biggest and most difficult challenges a patient can suffer from. There's 2 forms of hydrocephalus. There's non-communicating hydrocephalus, which means there's a tumor blocking the natural channels of CSF within the brain, but much more commonly with lepto, we see communicating hydrocephalus, which just means that the channels are open, but the brain is just less able to absorb the CSF. The ways that it can be highly symptomatic, and I will say this is often a leading cause of hospitalization at end of life. is because of severe positional headache. So you can envision brain is not absorbing the CSF. This leads to difficult headaches that are exacerbated by laying flat. You can imagine every time a patient wants to sleep, they're a little bit hypercapnic, they wake up with these debilitating headaches. Throw on some steroids, and these patients are really quite miserable from not being able to enjoy their days or their nights. We've all seen the sequelae of this as it progresses beyond headaches. It can lead to cognitive decline, gait disturbance, emesis, urinary incontinence, and in the horrible, in the late stages, it can lead to obtundation and visual loss. I already mentioned it's a leading cause of hospitalization, and there is a large population of patients in our practice that if you can reverse the hydrocephalus or help the hydrocephalus, those patients will want, and in many cases benefit from further CNS-directed or systemic treatment. And as we're talking about recumbency with hydrocephalus, that is something that, those symptoms of headache can be often reversed with shunting. Ventricular peritoneal shunting is something that we have a low threshold to do in our practice. We know that the survival is poor, but it's not that poor in patients who have good premorbid functional status. And I will say in our practice, we have most of these patients actually present to the hospital. They're admitted with severe symptoms. And in nearly all cases, those patients are able to be discharged home for end of life or for further treatment with their families. It is a surgical procedure, but it is effectively an outpatient procedure where patients go home the next day, usually 3 small incisions with a low complication rate. We do believe it is something important to offer patients who are otherwise cognitively there and feeling well. This is not, in our practice, glioblastoma where patients slowly fade away. These are patients who are cognitively very well and have time to benefit from with their family at home. And just a question that often comes up, can intrathecal therapy be delivered with a shunt? Theoretically, yes. We have valves that we can turn off so that the CSF stays in the head for the course of treatment. Practically speaking, we do find that hydrocephalus is rarely reversed, or intracranial hypertension is often not reversed. And so turning off the shunt can cause symptoms. And logistically speaking, at least in our practice, we like certain providers, typically the neurosurgeons, to be the ones to turn them on, turn them off. You can imagine a different providers infusing or instilling therapy. From a patient perspective, it can be a whole day of shuttling back and forth, and it's often impractical. Plus, if they have concomitant hydrocephalus, that CSF will later divert to the abdomen.
Thank you. And then just a few notes on cranial spinal radiation for leptomeningeal disease. This used to be tried decades ago and was discontinued because of toxicity of whole spine radiation. And you can see the radiation treatment plan there on the left. Not only were you treating the entire CSF space, but you were getting a lot of the marrow that's in the spine, as well as the organs in the chest, abdomen, pelvis that all cause symptoms, contributing to decline in performance status. But with proton radiation, the beam stops where we ask it to for the most part. And you can see for the plan on the right, the radiation beam comes from the back and treats the thecal sac and then stops. So we're able to significantly decrease the amount of normal tissue radiation exposure. And a prospective randomized trial conducted at Memorial Sloan Kettering Cancer Center led by Jonathan Yang, he randomized patients. These are non-small cell and breast cancer patients. I think 43% of them were breast cancer, so roughly half of them. Between proton CSI and whatever we would have done with radiation otherwise. Most of the time it was whole brain radiation, but you can see on the left, proton is in blue there. There's less CNS progression, which is rational because we actually sterilize the entire CSF space rather than just part of it in red with photons. In the middle, you can see there's better progression-free survival in blue with protons. And unlike any other study with radiation and CSI in the past for leptomeningeal disease, we actually for the first time showed an overall survival improvement. And this is really what has fueled cranial spinal radiation as a practice in management of leptomeningeal disease. In the same study, the limitation again isn't so much disease control, but toxicity. You can see that it's very modest toxicity. Protons in the grade 3, grade 4 column on the left was less to that than the involved field radiation with photons, so smaller fields, yet more toxicity overall. We already heard nodular leptomeningeal disease is likely a misnomer, but it's a term out there, so we're just going to acknowledge that it's there so we can still communicate with our colleagues. There is no standard of care. In terms of radiation therapy options, I agree with what has been said. I don't think of it as leptomeningeal disease, like an entire CNS space disease, but really you have to look at the actual disease itself. Sometimes it's just a little nodule, which is just a little dural met. We treat it with SRS. Sometimes we see it as a result of a craniotomy, or can even be a biopsy, and I always treat the entire surgical tract. I think that the seeding that people are now recognizing is only because they're backing off of whole brain radiation, but I've always done lots of partial brain radiation. This is an 80-year-old woman with a single brain met resected. She did great. She ended up dying a few years later unrelated to her oncologic disease, which is exactly what we wanted. And then, yes, of course, if it spreads, then it's not just nodular, but true LMD. You can have both as well, and then cranial spinal radiation can be considered as a radiation option. Trade-off, larger fields will control more disease, but certainly the trade-off of more potential side effects.
Great, so back to the case. Our patient did move forward with proton-based CSI, and then comes back to the clinic to discuss next steps with regards to systemic therapy. And I think one thing to know here is that she is less than 12 months from the completion of her adjuvant therapy, and that does impact our decision making. I wish I could say our toolkit was as full here as it is in the HER2 positive space, but unfortunately we do need a lot more data in this space for novel agents in the setting of HER2 negative disease. NCCN currently in the HER2 negative space relies largely on chemotherapy. I think that leaves us all very dissatisfied, but in fact we do have capecitabine, the platinums listed here. Other strategies in 2023, I would say there is very little, if any, data for LMD in this space, so we're going to extrapolate from what we know from parenchymal brain metastasis. Here we are seeing our antibody drug conjugates, TDXD, sacituzumab. TDXD here would be in the HER2 low space, and one of the questions from the virtual audience was, what is the activity of TDXD in HER2 low? And the answer is we don't really know yet. I think it's all been sort of case-based and anecdotal. I will say personally in my own practice, I have seen responses to TDXD in the HER2 low parenchymal brain metastasis space and in the LMD space, but we really need to pull together and publish some of that data. In addition, we do have some targeted therapies, particularly PARP inhibition, and we'll just briefly go through this in the interest of time. I think many of us know about sacituzumab, the TROP2 targeting ADC, also with a topoisomerase inhibitor payload. And interestingly, Dr. Brenner at San Antonio several years ago did a very nice window of opportunity study where a dose of sacituzumab was given prior to craniotomy in both the metastatic breast as well as GBM space, and saw respectable concentrations of sacituzumab in the CNS metastasis. Many of us are aware of the ASCENT clinical trial that evaluated sacituzumab versus physician's choice chemotherapy, and in fact there was a subset analysis that looked at the outcome of patients with CNS metastasis. Here you can see the median PFS for sacituzumab was 2.8 months versus physician's choice 1.6 months. I think we could all say here we'd like to be doing better. It has been shown in the literature that if you look at DNA damage repair capacity of brain metastasis compared to primary tumors as well as extracranial sites, you see deficient DNA repair capacity, and so a way to galvanize on this is to utilize PARP inhibitors. And here is the CNS metastatic subgroup from the EMBRACA study illustrating improved progression-free survival for talazoparib in the setting of a germline BRCA mutation for our patients with CNS metastasis, close to 6 months versus, interestingly, 1.6 months for chemotherapy. So very nice targeted strategy here. And sort of echoing one of the questions earlier is how do we incorporate many of these modalities together? And in fact, the SOLERA study, what the PI is Dr. Colette Shen in radiation oncology at UNC Chapel Hill, is evaluating the combination of olaparib with radiosurgery, followed by durvalumab with a choice of agents, one of which is olaparib, sort of channeling the presentation we saw this morning with KeyLink. So the other question is, should we consider intrathecal therapy? And really the indications for intrathecal therapy are symptomatic LMD, positive CSF, and controlled or absent extracranial disease. And I would say this constellation is usually a rarity. Historically, intrathecal methotrexate has been utilized. It's a twice-weekly administration that can be quite cumbersome. And more recently, we've seen data for IT topotecan, and this is the MD Anderson experience. You can see here about 61% of patients did have LMD from breast cancer. I think one of the things that was really nice in this presentation is they combined with many systemic therapies. Up to 60% of patients had concurrent systemic therapy, showing safety here with an overall survival of a little over 6 months. So after 8 months on systemic therapy, our patient unfortunately develops worsening symptoms and continued functional decline, and the patient and family ask what to expect next. And I think this is where it really is our duty to help support our patients to this transition to end-of-life care, and I'd love to turn over to Dr. Moss to discuss this in a little more detail.
Yeah, absolutely. I think we've heard lots of talk of aggressive therapy today, and I will say as a practitioner, it's very easy to project our wishes for local control, for CNS control at any expense, but I do think it's important to recognize that patients are entire beings that have many domains to their life that actually warrant consideration beyond just, can we control their brain metastasis? That's kind of the punchline here. And this has been recognized by the World Health Organization, by ASCO. I think we're often way too late in considering involving our palliative care and really broadening the care team to include all of these different aspects into their care. And just to recognize that brain metastasis is an advanced form of disease. This is we know that the prognosis is still quite short, despite our best efforts and despite anecdotal cases of many patients living years. And I will say that many patients really do benefit from us recognizing, as I said before, all the aspects of their well-being that can include spirituality, that can include, chaplaincy, that can include social networks among, patient advocacy groups or other patients, can include being open and honest with their organic social network, with their loved ones, with their friends who can really help them process spiritually, psychologically, what they're going through. From a physician perspective, I think it's important for us to be very honest and direct about what we can expect, provide as much information as we can, and to really serve as a gatekeeper for these other resources that we're talking about. This figure shows that, while I might think that I'm the key for my patient during the surgical episode, while all of us think that we're the key at our given moment, it's very easy to forget that it may be, again, the chaplain, the pharmacist, the neuro-oncologist who recognizes that dexamethasone is that patient's major problem right now. So I would encourage everyone to think broadly about how do we expand this for each patient early on. And in many cases, less aggressive therapy has been shown actually to provide prolonged survival. We think that, hitting a patient's brain with more, hammers and scalpels and lasers and medications and radiation might actually help. But in many cases, and this has been seen across different oncologic types, that actually sometimes stepping back, allowing the disease to take its course a little bit if a patient needs a break, might actually provide the well-being, the optimism, the immune restoration, the functional status preservation, the hope that actually might be much more important for these patients. And this has been validated. There's lots of prospective data, including this wonderful study in The Lancet from our Canadian colleagues showing that early implementation of a palliative care cluster for patients actually can prolong many aspects of well-being.
Excellent. Well, we are right at the top of the hour. I cannot thank my esteemed colleagues enough for being here and sharing their expertise. I think this session really highlights the first bullet point, is that the care of our patients with brain metastasis is by necessity multimodal and requires really close collaboration between our multidisciplinary partners to really think through the sequencing. Apologies. Oh, slides are done. Hold on. How we should mitigate long-term side effects for our patients, reflecting their neurologic and their overall goals. I think we've heard a lot about advances in neuroimaging, local systemic therapy options, treatment of late effects. And just to remember, at present, brain metastasis do remain incurable, but I feel very strongly that with continued coordinated research, interaction from bench to bedside, we will see our patients living longer and better. So thank you all for your attention today. We truly appreciate it.